This is Professor Capron. Welcome to this presentation on atrial fibrillation. Let's take a look at the learning objectives for this presentation. By the end of this presentation, you will be able to identify the ECG characteristics of atrial fibrillation, understand the physiological mechanisms underlying atrial fibrillation, assess the clinical presentation and associated symptoms of atrial fibrillation, discuss medical and nursing management strategies for atrial fibrillation, and recognize conditions commonly associated with atrial fibrillation. These are the key terms for this presentation. Please pause the video and make sure you get these down. If you still don't understand them at the end of this presentation, please make sure to come see me in class to discuss it. Let's take a look at the ECG characteristics of atrial fibrillation. In atrial fibrillation, the atria experience chaotic electrical activity, leading to the absence of distinct P waves. Instead of clear, regular P waves, you will see fibrillatory waves. These are small, irregular oscillations that replace the P waves and reflect the disorganized atrial activity. These fibrillatory waves vary in amplitude and frequency, creating a wavy baseline on the ECG. One hallmark of atrial fibrillation is the irregularly irregular rhythm of the ventricular response. Unlike a normal rhythm where the R to R intervals, the time between successive QRS complexes are consistent, in AFib, these intervals are irregular and unpredictable. This irregularity is due to the erratic firing of electrical impulses in the atria, leading to inconsistent conduction through the AV node to the ventricles. The ventricular rate in atrial fibrillation can vary widely. While the atrial rate is typically very high, over 300 beats per minute, not all of these impulses get through to the ventricles. The AV node acts as a gatekeeper, allowing only some impulses to pass through to the ventricles. This results in a ventricular rate that can be rapid, normal, or even slow, depending on the filtering effect of the AV node and any medications the patient might be taking. In AFib, the QRS complexes themselves are usually normal in duration, measuring between 0.06 to 0.12 seconds. This is because atrial fibrillation primarily affects the atria, and the ventricles depolarize normally unless there is an additional issue. However, if there is an underlying bundle branch block, the QRS duration may be prolonged. Let's take a look at the physiology of atrial fibrillation, or AFib, to understand why this arrhythmia occurs and its implications for cardiac function. Atrial fibrillation is characterized by erratic electrical impulses originating in the atria. Instead of the SA node generating a regular rhythmic signal, multiple sites within the atria fire chaotically. This disorganized electrical activity prevents the atria from contracting in a coordinated manner. Normally, atrial contraction helps to kick additional blood into the ventricles, a phase called atrial kick. In AFib, the loss of this coordinated contraction means the atria merely quiver instead of effectively pumping blood. This results in inefficient movement of blood from the atria to the ventricles. Because the atria are not contracting effectively, blood can pool in the atrial chambers. This pooling or stasis of blood significantly increases the risk of thrombus or clot formation. Thrombi formed in the atria can dislodge and travel through the bloodstream. If a clot travels to the brain, it can cause a stroke. This is a major risk in patients with atrial fibrillation and highlights the importance of anticoagulation therapy in these patients. Thrombus formation is particularly common in the left atrial appendage, a small outpouching of the left atrium where blood flow is often the slowest. The atrial contribution to ventricular filling, again known as the atrial kick, is lost in AFib. Normally, this contributes about 20 to 30% of the total ventricular filling volume. Without the atrial kick, the ventricles rely solely on passive filling during diastole. This reduction in filling can significantly decrease the stroke volume and overall cardiac output. Reduced cardiac output can lead to symptoms such as fatigue, dizziness, shortness of breath, and decreased exercise tolerance. In severe cases, it can precipitate heart failure, particularly in patients with pre-existing heart conditions. Let's discuss how to assess a patient with atrial fibrillation. Patients with AFib often report feeling palpitations, described as a fluttering, pounding, or racing sensation in the chest. These are caused by the irregular and often rapid heart rate. Due to inefficient pumping of the heart and reduced cardiac output, patients commonly experience fatigue. This can be particularly noticeable during physical activity when the body demands more oxygenated blood. The decreased cardiac output can lead to reduced blood flow to the brain, causing dizziness or lightheadedness. This is a significant symptom that can impact the patient's daily activities and increase the risk of falls. As the heart struggles to pump effectively, fluid can back up into the lungs, leading to shortness of breath. This symptom may worsen with exertion or when lying flat. Regular monitoring of blood pressure is crucial as AFib can cause fluctuations. Hypotension, low blood pressure, can occur due to decreased cardiac output, while some patients might experience hypertension, high blood pressure, as a response to the irregular heart rate. AFib can cause a rapid ventricular response, leading to a high heart rate. It's essential to monitor this to manage and control the rate effectively, often aiming for a rate under 100 beats per minute in chronic AFib patients. We need to assess overall hemodynamic stability. Look for signs of decompensation, such as altered mental status, severe hypotension, or signs of heart failure like peripheral edema or jugular venous distension. Unstable patients may require immediate intervention. In acute settings or for hospitalized patients, continuous ECG monitoring is vital to detect AFib episodes, especially if they are intermittent, which is paroxysmal AFib. This helps in assessing the duration, frequency, and rate control of AFib. For outpatient management or stable patients, routine ECGs are useful to confirm the diagnosis of AFib, monitor the effectiveness of treatment, and detect any progression or complications. Regular ECGs can help track changes over time and guide adjustments in therapy. Look for the absence of distinct P waves, the presence of fibrillatory waves, and an irregularly irregular ventricular rhythm. Ensure accurate interpretation, as AFib can sometimes be confused with other arrhythmias. Let's discuss the medical management of atrial fibrillation. Effective management aims to prevent complications such as stroke, control the heart rate, restore normal rhythm, and in some cases, eliminate the arrhythmia. One of the most crucial risks associated with AFib is the development of blood clots in the atria due to the irregular and often rapid contractions. These clots can travel to the brain, causing a stroke. So, warfarin is an oral anticoagulant that requires regular blood tests to monitor its effectiveness and ensure that the dosage is appropriate. Patients on warfarin need to be educated about dietary restrictions, as certain foods high in vitamin K can affect its action. Then there's also direct oral anticoagulants, and these include medications like dabigatran, rivaroxaban, apixaban, and edoxaban. They are often preferred over warfarin as they have fewer dietary restrictions, do not require routine blood monitoring, and have a more predictable anticoagulant. Then we might have beta blockers, medications like metoprolol and atenolol, used to slow the heart rate by blocking the effects of adrenaline on the heart. They help maintain a controlled heart rate, reducing symptoms and preventing complications related to a rapid heart rate. Calcium channel blockers like diltiazem and verapamil are commonly used to slow the heart rate by inhibiting the calcium influx in heart cells, which is necessary for contraction. Digoxin increases vagal tone, which slows conduction through the AV node, effectively controlling the heart rate, and can be used in patients who have heart failure. Then there's antiarrhythmic drugs. This is medication amiodarone, flecainide, and sotalol. These are used to restore and maintain a normal heart rhythm by modifying the electrical properties of cardiac cells. This electrical cardioversion involves delivering a controlled electric shock to the heart to reset its rhythm back to normal. It is typically used when medications are ineffective or in acute situations. Patients are usually sedated during this procedure to avoid discomfort. We might also have to do what's called a catheter ablation. This minimally invasive procedure involves threading catheters through blood vessels to the heart, where high frequency energy, radio frequency ablation, or cryo is used to destroy or ablate small areas of heart tissue that are causing the abnormal rhythm. The goal is to isolate the pulmonary veins or modify arrhythmogenic tissue to prevent the erratic electrical signals that cause AFib. Ablation is considered for patients with symptomatic AFib who have not responded to medication or for those who prefer a non-pharmacologic treatment approach. It can significantly improve quality of life and reduce AFib recurrence. Now let's talk about nursing management of atrial fibrillation. For hospitalized patients, continuous ECG monitoring is crucial to detect any changes in heart rate and rhythm. This helps in identifying episodes of AFib and monitoring the effectiveness of treatments. For outpatient management, regular ECGs are necessary to ensure the patient's heart rate and rhythm are controlled. Common symptoms include palpitations, shortness of breath, chest pain, fatigue, and dizziness. Regularly assess patients for these symptoms as they can indicate the effectiveness of treatment or the need for adjustments. Encourage patients to keep a log of their symptoms, noting the time, duration, and any potential triggers. This can provide valuable information for tailoring treatment plans. Because of the risk of stroke, make sure to use the FAST assessment if necessary. That stands for face drooping, arm weakness, speech difficulty, and time to call 911. This method can quickly identify potential stroke symptoms. Immediate intervention is critical to reduce the impact of a stroke. Regularly perform neurological assessments to detect any subtle changes that might indicate a stroke. Look for signs of deep vein thrombosis, such as swelling, pain, and redness in the legs. DVTs can break off and travel to the lungs, causing a pulmonary embolism. Monitor for sudden shortness of breath, chest pain, and coughing up blood, which are all signs of a pulmonary embolism. Emphasize the role of anticoagulants in preventing stroke. Explain how these medications help prevent clot formation in the atria. Stress the importance of taking anticoagulants consistently and as prescribed. Skipping doses can significantly increase the risk of stroke. Educate patients on the importance of taking their beta blockers, calcium channel blockers, or antiarrhythmics regularly to maintain a stable heart rate and rhythm. Inform patients about possible side effects and when to report them to their healthcare provider. Advise patients to limit their intake of alcohol and caffeine, as both can trigger AFib episodes. Explain how these substances can increase heart rate and promote arrhythmias. Encourage patients to engage in stress reduction techniques such as yoga, meditation, deep breathing exercises, or any activity that helps them to relax. Suggest counseling or support groups for patients experiencing significant stress or anxiety. Emotional well-being is crucial in managing AFib. Recommend a heart-healthy diet rich in fruits, vegetables, whole grains, lean proteins, and healthy fats. Reducing sodium and unhealthy fats can help to manage blood pressure and overall heart health. Encourage moderate exercise tailored to the patient's fitness level. Regular physical activity can improve cardiovascular health and reduce AFib episodes. Let's talk about typical patient presentation in atrial fibrillation. AFib can lead to fluctuations in blood pressure, and maintaining stable blood pressure is essential to prevent complications. So regularly check the patient's blood pressure to ensure it remains within the normal range. Be alert for signs of low blood pressure, which can occur if the heart isn't pumping effectively due to the AFib, but also watch for high blood pressure, which can exacerbate AFib and increase the risk of stroke. AFib also often causes an irregular pulse. Palpate the radial pulse and confirm the irregularity with an ECG. Document the irregular rhythm and any significant rate changes. Monitor the rate closely. AFib can cause rapid heart rates, tachycardia, or occasionally slow rates, bradycardia. Both can have significant clinical implications. Observe the patient's respiratory rate and effort. AFib can lead to shortness of breath, particularly if it affects cardiac output and pulmonary circulation. Establish a baseline respiratory rate for the patient and watch for any deviations that may indicate worsening symptoms or complications. Patients with AFib also often describe palpitations as a fluttering, racing, or irregular heartbeat. Ask patients to describe their palpitations, including frequency, duration, and any associated activities or triggers. Assess how palpitations affect the patient's daily activities and overall quality of life. Palpitations can cause significant anxiety and discomfort. AFib can lead to decreased cardiac output, resulting in fatigue. Ask patients about their energy levels and ability to perform usual activities. Determine if the fatigue is constant or occurs intermittently, and if it correlates with episodes of AFib. Inquire about episodes of dizziness or lightheadedness. Dizziness can result from decreased cerebral perfusion due to AFib. Be aware of any history of syncope or fainting, which can indicate more severe hemodynamic instability. Ask about any difficulty breathing, particularly during physical activity or when lying down. Shortness of breath can occur if AFib leads to pulmonary congestion or heart failure. Determine if the patient experiences orthopnea. This is shortness of breath when lying flat, or paroxysmal nocturnal dyspnea, which is sudden shortness of breath at night. These are signs of worsening cardiac function. Evaluate the patient's ability to perform daily activities, such as walking, climbing stairs, and household tasks. Note any limitations or changes in activity levels. Understand how symptoms like fatigue, palpitations, and shortness of breath impact the patient's ability to engage in these activities. And assess the patient's exercise tolerance. Ask about any changes in their ability to participate in physical activities or exercise routines. Determine if symptoms worsen with physical exertion, which can provide insights into the severity and impact of AFib. Talk about some conditions that are commonly associated with atrial fibrillation or AFib and understand the significance of these relationships. Hypertension is one of the most common risk factors for AFib. Studies have shown that individuals with high blood pressure are significantly more likely to develop AFib than those with blood pressure. Chronic high blood pressure can lead to structural changes in the heart, such as left ventricular hypertrophy and atrial enlargement. These changes can create an environment conducive to the development of AFib. Effective control of blood pressure is crucial in reducing the risk of AFib. This includes lifestyle modifications such as a low sodium diet, regular physical activity, and adherence to antihypertensive medications. There is a bidirectional relationship between AFib and heart failure. AFib can exacerbate heart failure symptoms, and conversely, heart failure can increase the risk of developing AFib. In heart failure, the heart's ability to pump blood effectively is compromised. This can lead to increased atrial pressure and dilation, which predisposes patients to AFib. Additionally, AFib can worsen heart failure by reducing cardiac output and contributing to further fluid retention and congestion. Managing patients with both AFib and heart failure requires a comprehensive approach, including optimizing heart failure treatment, controlling the heart rate, and considering anticoagulation to reduce the risk of stroke. Patients with diabetes have a higher risk of developing AFib compared to non-diabetic individuals. This increased risk is due to several factors, including the presence of comorbid conditions and the effects of hyperglycemia on the cardiovascular system. Diabetes can lead to changes in the myocardium, including fibrosis and autonomic dysfunction, which can predispose patients to AFib. Additionally, diabetes often coexists with other risk factors such as hypertension and obesity, further increasing the risk. Effective glycemic control is essential in reducing the risk of AFib. This involves regular monitoring of blood glucose levels, adherence to anti-diabetic medications, and lifestyle modifications. Additionally, managing conditions such as hypertension and obesity is crucial. Excess thyroid hormone levels can lead to an increased heart rate and heightened sympathetic activity, both of which can trigger AFib. Hyperthyroidism should always be considered in patients who present with new onset AFib. Although less common, hypothyroidism can also be associated with AFib, particularly when it leads to increased systemic vascular resistance and hypertension. So, regular screening for thyroid function is important in patients with AFib, especially if there are symptoms suggested of thyroid dysfunction. Treating the underlying thyroid disorder can often help in managing AFib. For hyperthyroidism, options include antithyroid medications, radioactive iodine, or surgery. For hypothyroidism, thyroid hormone replacement therapy is the mainstay of treatment. So let's do a quick summary of what we've learned in this presentation. You learned that atrial fibrillation is identified on an ECG by the absence of distinct P waves, which are replaced by fibrillatory waves. The ventricular response is irregularly irregular, meaning that the intervals between QRS complexes vary without any kind of consistent pattern. Despite the chaotic atrial activity, the QRS duration typically remains normal unless there's an underlying bundle branch block. Remember, the hallmark of AFib is the irregularly irregular rhythm and the wavy baseline without distinct P waves. These features differentiate it from other arrhythmias. Atrial fibrillation occurs due to disorganized electrical activity in the atria, leading to rapid and irregular atrial contractions. This can be caused by various factors, including structural heart changes like atrial enlargement, electrophysiological abnormalities, or systemic conditions like hypertension, hyperthyroidism, and diabetes. The disorganized atrial activity results in ineffective atrial contraction, which contributes to stasis of blood in the atria. This stasis increases the risk of thrombus formation, which can lead to thromboembolism and stroke if a clot travels to the brain. Because the atria do not contract effectively, there is a loss of atrial kick, reducing ventricular filling and thus decreasing cardiac output. This can lead to symptoms like fatigue, dizziness, and shortness of breath. Continuous or routine ECG monitoring is essential for detecting and managing AFib. Early identification allows for timely intervention to control the heart rate and rhythm, reducing symptoms and preventing complications. One of the most significant risks of AFib is the potential for thromboembolism, particularly stroke. Therefore, anticoagulation therapy is a critical component of management to prevent clot formation and reduce the risk of stroke. Managing AFib requires a multifaceted approach, including the use of rate control medications like beta blockers or calcium channel blockers, rhythm control strategies like antiarrhythmic drugs or cardioversion, and lifestyle modifications. Patient education on medication adherence and lifestyle changes is crucial to improving outcomes. And you also learned how conditions such as hypertension, heart failure, diabetes, and thyroid disorders are often associated with AFib. Effective management of these underlying conditions can help to control AFib and prevent its recurrence. Thank you so much for paying attention to this presentation. Make sure that you're getting enough sleep and enough to eat, and then go out there and do some nursey things.